Okay. Okay. Hello, everyone. My name is Sulafa Al-Hassan. I would give like overview of SPSS data analysis. So can you see my screen?
Yes.
Okay. So in general, basic statistic have two ways to use statistic. We have two ways to use statistic, either descriptive or inferential. I would like to start by type of variable so we can have understand of like how we will use the basic statistic in SPSS. We have categorical variable and we have numerical variable. The categorical variable have many subgroups, like we have nominal, binary, and ordinal. The nominal one, no order for it. For example, race and religious, so we cannot like order it. For race, we can say African American, we can say white, but we cannot order it. Other type is binary. It's type of nominal variable. It have two categories. For example, gender, we have either male or female. If we have a disease, for example, COVID, and we test a group of patients, so we can say either it is present or absent. Usually this type have two options to label our variable. We have also the ordinal. The ordinal is two or more categories that have a natural order, so we can order it. For example, agree, we can say like strongly agree or agree and disagree. Also, first grade, second grade, third grade, so we can order our variable by naming them. The second type of variable is numerical variable. It either can be continuous or count. For continuous variable, we have it have synonyms. We can say it is quantitative or interval or scale. And the variable can take on real value number. For example, 15.7, 50.749, or 2,478.92, or negative 8.6. So it has value we will put in our variable. This is an example of how we label the blood pressure, temperature, and all of continuous variable. Also, we have the count variable, and this can only take integer value. For example, if we have questionnaire and we ask the family, how many children do you have? So the answer will be 2, 3, 4 without decimal. So this is the other type of numeric variable. So SPSS have many ways to do data analysis. It can calculate the standard measure of central tendency, mean, median, and mode. And this mainly, we use this mainly with, we use this mainly with continuous variables. So if we have temperature and would like to give central tendency estimation, we can use either median, mean, median, and mode. And there is different, as you know, on when to use the mean or median and mode. Also, we can create histograms, frequency distribution, stem and left plot, 2-key box plots. This is like visual display of our data. So it's easy when you take a look to histogram, you can you can very quickly determine the data of like value of the data. We can also calculate the standard measure of discipline, range, semi-interquartile range, and standard deviation, variance. All this simply you can give any command to the SPSS and it displays for your data set all this analysis. It can calculate also measure of skewness. Okay, so we have many commands that we can put to SPSS to like, to display. So we have the frequency command. The frequency command can be used to determine many functions. For example, we can have quartile, percentile, measure of central tendency. As I mentioned before, the mean, median, and mode. Also measure of dispersion range, standard deviation, variance, minimum and maximum. Also it gives this measurement, and measure of skewness. Also, as I mentioned before, it creates the histogram and box plots. So I put here some notes, but I want to show you it in SPSS. So you will go to analyze, then there is the window pop-up for descriptive statistic, and you go to frequency. I will show you this step in minutes in SPSS. If you want frequency distribution, you can select display frequency table. After that, you will specify which statistic you want to perform by clicking on the statistic button. If you want to have like some visualization of your data, you can specify the chart you want to by clicking on the chart button. So the requested statistic and chart will appear on the SPSS output viewer. You will see it like the table with all chosen one, like percentile, cumulative, anything, it will be there. The output viewer has two columns. The left will show the statistic you choose, and the right, the value of the statistic. If you see skewness, it will be like greater than 0. The skewness, sometimes the number, I have data which the skewness is 0.7. So if the data is skew, it will be more than 0, and the value distribution is skew. And the histogram, you will see it down. Just scroll down, you can see the histogram. We have also descriptive command. This used to measure the quartile, percentile. Also, it can measure center of tendency, like this. It is displays this value, mean, median, and mode. Also, it measure of dispersion, range, standard deviation, variance, minimum and maximum, and it measure also if there is skew, right or left skew, you can also see it. I will show you this in a minute. You can find it at analyze descriptive statistic, then go to descriptive. So the previous one, we found it under frequencies, but here you will choose descriptive and use the option button to specify the statistic you would like to choose. So this is the reference. I will show you now how we can do this in real life. Can you see my screen? Okay, so we have this data. Okay, just we have this data, and we, as I mentioned, we will go to analyze. We'll go to descriptive statistic, and we'll choose first the frequency. Now you can select from here what variable you want to display and do analysis on it. We can use, for example, lab value. You will just press on this button. So it takes this variable right here, and you will go to statistics. Here you can choose just the central tendency if you want mean, median, mode. And you can also choose from the percentile value, like percentile. Here you should choose what level of percentile. So I can choose up to 95 percentile. Then I will press add. And I will press continue. Also, we can choose, for example, standard deviation, variance, whatever you want, whatever you think this will help you in your analysis, the skewness also. Continue, and this, when this appear again, we will select OK. So now this is the table, the result, and as I mentioned before, you will see the statistic you chose. Yes.
The window will not appear for us.
Okay,
we're
sorry.
Still on the data view.
Okay, I will share again. Thank you, Dr. Nader.
If you can share the whole window.
Screen? Okay. Okay, I will choose the screen. Okay. Can you see it all now?
Yes.
Thank you, Dr. Nader. So here, the table, you will see the statistic you choose here on your left side and the value of it on your right side. For this example, our mean is 17, the median 8, and our mode is 5.10. Also, we choose before this standard deviation. You can see it here, the variance, the skewness. And as I mentioned before, if it is more than 0, that means we have a skewed distribution. So when we scroll down, you can see, because I choose the percent, also I want the percent, you can see here this table with percent and cumulative percent. If I choose only mean, mode, and median, you will not see this value right here. So this is our range from our data. And we choose, and this is the total. If you have any missing data, it will appear here. We have one missing, so it appears here. So you will not save it. Okay. Also, we can do the descriptive, and the same result can pop up. From the descriptive. Here we can press on options, and you will see what option. The previous one is still it's saved because I chose before the standard deviation and minimum and maximum. So we can also continue on it and press OK. And it shows just in different view. It will show you the number of lab value we have in our dataset and the minimum number, the maximum value, its mean, and its standard deviation. And also, if you want to display your histogram, we can go to frequency here, and you can press on chart. If you want bar chart, pie chart, or histogram, you can press here, press continue, and then OK. And by the end of all the data before we have seen, you can see the histogram by the end of it. You can also print your data, like export it. If you have this data and you want to send it via email, you can export it in Word document, for example, and send it to, or email it for anywhere. So do you have any question? Okay, so that's all what I have for today. Thank you so much.
Thank you, Dr. Sulafa, for the informative presentation. Now, Dr. Amna. Dr. Amna will present the respiratory disease.
Assalamu alaikum.
Walaikum assalam wa rahmah. Go ahead.
Can you hear me well?
Yes.
Yes.
Can you see my screen?
Yes.
Okay. So I am going to present to you respiratory diseases in elderly. First, there is age-related pulmonary changes that happens in elderly patients. They usually encounter reduced airway size and they have shallow alveolar sacs. And there is decline in chest wall compliance as a result of osteoarthritis of costovertebral joints and calcifications of costal cartilage. So the chest wall doesn't expand like in younger populations. And there is intercostal muscle atrophy and reduction in diaphragmatic strength. All these predispose them to more respiratory diseases and may confuse the diagnosis. They also have decreased forced vital capacity and decreased forced expiratory volume in 1 second. The common respiratory diseases that happens in elderly populations are asthma, COPD, and obstructive sleep apnea, idiopathic pulmonary fibrosis, pulmonary thromboembolism, and pneumonia. I will talk a little bit about all of them. First, I'm going to talk about asthma. Several studies in European and US populations have shown that asthma prevalence among people aged over 65 years old range from 1.8 to 8.9. Asthma is under-recognized and under-treated in older adults because symptoms in elderly may differ from the younger populations, and perceptions of illness in elderly differs also from the young populations. Following childhood, prevalence of asthma peaks again after age of 65. That is what's called late onset asthma. Usually there is difficulties in diagnosis of asthma in elderly because performing spirometry is usually used for diagnosis of asthma, but in elderly there is a mild cognitive impairment, so this affects the test result. And there is an 8-toler test that can be used instead to adjust these misinterpretations. Like we can use the forced expiratory volume in the first 6 seconds instead of using forced vital capacity, because I said earlier, the forced vital capacity in the elderly population has decreased, so we can use the forced expiratory volume in the first 6 seconds to diagnose asthma. Also, the spirometric curves are used in diagnosis of asthma. There is incorrect interpretation of them in elderly because the physiological changes in respiratory system due to normal aging process may confuse the picture. Also, there is something called senile lungs, which are the changes that happens in elderly, make the lung different than younger populations. This may confuse the picture in diagnosis and may be misdiagnosed as having, for example, emphysema. In saline lungs, there is hyperinflation, but in emphysematous lung, we have also destruction of lung parenchyma in addition to hyperinflations. And in saline lungs, there is homogeneous enlargement of alveolar air spaces, but in emphysematous lung, there is a heterogeneous enlargement of the alveolar sacs. Also, there is difficulty in differentiation asthma from COPD, but a major characteristic is that in asthma that the diffusion capacity of carbon monoxide is normal, and in COPD there is decreased diffusion capacity of carbon monoxide. Also in asthma, we have atopy as the patient have allergy to other irritant, and in COPD there is no atopy. The pharmacological challenges that may encounter in treating asthma of elderly is comorbidity, because elderly populations have more comorbid disease like heart, lung, and kidney diseases that may affect the efficacy of the treatment. And there is polypharmacotherapy, as they have other drugs that they use for chronic diseases that may affect or interact with the asthmatic drugs. And the pharmacokinetic changes that happen in elderly populations, like there is decline in liver and kidney functions, which may affect the secretion of drugs, and we may encounter more side effects. Treatment of geriatric asthma. The inhaled corticosteroid as a cornerstone of pharmacological management of patients with persistent asthma at all ages. However, in geriatric populations, high doses of inhaled corticosteroids may increase the risk of adverse events. And the patient inhalation technique and peak inspiratory flow, which are variably impaired in elderly populations, can increase the occurrence of side effects like skin bruising, osteoporosis, bone fracture, cataract, oral candidiasis, diabetes, and pneumonia. So we usually use the minimum efficacy dose of inhaled corticosteroid, and we should have closer clinical follow-up to monitor for any side effects or under treatment. And if we have to use enzyme inhibitors for any reasons, we should use steroids that is metabolized through hydrolysis like clomifene, because enhanced enzyme inhibitors may affect the pharmacokinetics of steroids. The second drugs are beta-2 agonists. The response to the beta-2 agonist is different in elderly asthmatics because they have increased sympathetic activity, and this may affect the metabolism, the efficacy of drugs. The drug work different between young and elderly populations. The major side effects of beta-2 agonists are hypokalemia, because they induce intracellular absorption of cellular movement of potassium. And in ECGs, we have QT prolongations, tachycardia, tremor. Alternative to beta-2 agonist is anticholinergic drugs. Also, the anticholinergic response is different in older populations due to decrease in parasympathetic activity and reduction of receptor number for both receptor coupling with age. The most frequent side effects are dry mouth and ambulation test. Also, there is decrease in GIT motility. There is urinary hesitancy and exacerbations of glaucoma in people who have glaucoma. And there is also mild cognitive impairment. And last thing is paradoxical bronchoconstrictions, which may occur sometimes. Regarding the thiophyllene in geriatric asthma, this drug has a narrow therapeutic range, which may make it least favorable for managing of geriatric asthma. And it interacts with several drugs, and the pharmacokinetics different from one patient to another. It carries the highest frequency of side effects in elderly, which are GIT symptoms and arrhythmias. Several studies have demonstrated that thiophyllene metabolism and clearance decrease in the elderly. It actually decreased by 22 to 35% in elderly people, and is further decreased if they have concomitant diseases, particularly liver and heart disease. So it's very dangerous to be used in elderly. Regarding leukotriene receptor antagonists are alternative treatment if we can't use inhaled corticosteroid and long-acting beta agonist in elderly. For example, in patients with heart failure or ischemic heart diseases, there is difficulty in using the beta agonist. So we can use instead leukotriene receptors antagonist. We use monoclonal antibodies, IgE antibodies, in patients with severe asthma. But before treatment, we measure the level of IgE. If the patient has high IgE levels, the drug will be more effective. Yeah, I have a couple of questions regarding asthma. The first one, which of the following is true for a 75-year-old patient with fixed airflow limitation and a history of asthma from adolescence? A, they should be treated as COPD patient. using inhaled bronchodilator as first-line therapy, or they should be treated as an asthmatic patient using inhaled steroid, or skin prick tests are mandatory before initiating treatment, or radiology is necessary to exclude COPD. So you can interact in the chat. So I have two answers of A. The answer is B. They should be treated as an asthmatic before they have a history of asthma from adolescence using inhaled steroid. Okay. Which of the following algorithms should be used in diagnosing asthma in elderly? Clinical history, spirometry, bronchodilator, diffusion of carbon monoxide, skin prick test, or skin prick test, chest radiography, spirometry, diffusion of carbon monoxide, bronchodilator test, or high resolution CT of the chest, spirometry, bronchodilator. And the last options is clinical history, skin prick test, and chest X-ray. Yes, correct. The answer is A. We diagnose asthma by clinical history, spirometry, bronchodilator test. In asthma, we have reversibility. If we give bronchodilator drugs, then we measure the lung function test. There's reversible airway constriction. And by measuring diffusion of carbon monoxide, I said earlier it is normal, and skin prick test. Okay, 70-year-old man has a poor control asthma despite use of control medications because the physician evaluates the patient eligibility to anti-IgE treatment. No, because clinical trials have not investigated the effectiveness of monoclonal antibodies in the treatment of severe asthma in geriatric population, or no, due to modifications of the immune system associated with aging. Yes, published data have confirmed that omalizumab in elderly asthmatic is effective as in younger populations. And no, it is used in clinical practice is strongly linked by the risk of side effects. Yes, correct. It is C. We use monoclonal antibodies in management of geriatric condition and to work similar to the younger asthmatics. So we are going to talk about chronic obstructive pulmonary diseases. It is a disorder of chronic inflammatory lung disease that causes obstructed airway flow from the lungs. It has two types, chronic bronchitis and emphysema. The symptoms include breathing difficulty, cough, which is usually productive cough, and wheezing. People with COPD are at high risk of developing heart diseases, lung cancer, and variety of other conditions. Chronic bronchitis is inflammation of the lining of the bronchial tubes, which carry air to and from the alveoli in the lung, characterized by daily cough and mucus production. The bronchial tubes became inflamed and narrowed, and lung produce more mucus, which may further contribute to increase the narrowing, and the patient have cough trying to clear the airways. In this, we see that this is a normal bronchial tube, and this is a narrowed bronchial tube due to obstructions and increased mucus. In emphysema, the alveoli is damaged, are destroyed as a result of exposure to cigarette smoke and other irritant gases and particulate matter. Small airways collapse. Excuse me. Sorry. In emphysema, the restriction of the alveoli, and in chronic bronchitis, we have destruction in the bronchioles. So the alveoli, when we exhale, it collapses, and this is impairing outflow of the air from the lung. Here we see the damage in the alveoli. The COPD is the fourth leading cause of death in the US, and it is leading cause of disability as measured by disability adjusted life years. It's a typical disease of aging. The incidence of COPD increases with age, ranging from about 6.6 in the age group of 45 to 54, and it's about 12% in age more than 64. The prognosis is poor. The 3-year mortality from COPD in COPD populations has been reported to be 23. The COPD patients with a mean age of more than 65 years, mortality was best predicted by a composite index named BOOD index. This is actually used for measuring the mortality and severity. The BOOD index usually is assessed by using the B for BMI. We measure the nutritional status of the patient, and O, I think it is obstruction. We measure the obstruction by using forced expiratory volume in 1 second, the D for dyspnea, and E for exercise capacity. So we said that the elderly populations have lung changes that happens. There is similarity in changes due to aging and due to COPD. In both conditions, we have a decrease in vital capacity, but the decrease is more with COPD patients, and there is increase in residual volume as the elderly patient have decreased chest wall compliance. This results in not completely exhale the all air in the lungs, so there is increase in residual volume. But in COPD, there is more increase in residual volume, and there is decrease in elastic recoil and the mucociliary clearance, mucosal immunity, and vascular reserve. The risk factors of COPD are smoking and people with asthma. There is actually a risk factor of having COPD in asthmatic patients, and the risk factor for developing COPD even is higher if we have asthmatic patients who also smokes. Occupational exposure to dust and chemicals, and exposure to fumes, and genetics. The uncommon genetic disorders like alpha-1 antitrypsin deficiency is the cause of some types of COPD. Diagnosis is based on history, physical examinations. We have parachute shape test. We have hyper resonance on percussions because there is more air in the lungs, and the forced expiratory volume more than 9 seconds measured during clinical bedside examination. We perform spirometry, and we measure the ratio between forced expiratory volume in 1 second and forced vital capacity. If the ratio is more than 0.7, there is obstructive lung disease. This ratio actually decreases with age. So age itself can explain a decreased ratio. So using a fixed ratio to separate normal from obstructive diseases carries the risk of overdiagnosis of COPD in older adults. We measure lung volume and diffusion capacity of carbon monoxide. We can do 6-minute walk test and pulse oximetry. We can do imaging like X-ray and CT scan, and also we can do ABG test. We measure the severity of COPD using the ABCD assessment. It includes parametric assessment of airflow obstructions in 1 second, respiratory symptoms using a dyspnea scales, and we can go in the history to see the exacerbation, exposure to exacerbation agents like smoking. We can see the frequency of hospitalization. So after doing that, the disease severity is ranked from the least severe form A and the most severe form D. COPD. We measure the dyspnea, and could you hear me? Because they say the internet connection. Hello? Hello?
Yes. We can hear you, Amna.
Okay.
Yes.
We measure the dyspnea. We ask about chronic cough and sputum productions. We ask about history of risk factors like smoking, exposure to oxidation dust and chemicals. And we ask about family history and genetic variants like alpha-1 antitrypsin deficiency. Then we do a spirometry, and the ratio, I said, less than 0.7. We measure after measuring the ratio, we measure we see the forced expiratory volume in 1 second. If it is more than 80, it is mild. If it is between 50 and 80, it is moderate, and if between 30 and 50 is severe. Less than 30% is very severe COPD, or if it is less than 50 and patient have forced respiratory failure, also it is regarded as very severe COPD. Regarding management phase, we advise the patient if he smoked to stop smoking, and the first line drugs is inhaled bronchodilators, beta-2 agonist, or anticholinergic drugs. We start with monotherapy with long-acting beta agonist or anticholinergic for symptomatic patients whose forced expiratory volume in 1 second is less than 60%. When the symptoms progress, we can advise to add inhaled corticosteroids. If the symptoms is refractory despite the use of maximum inhaler therapy of long-acting beta agonist and inhaled corticosteroid, we can add a selective phosphodiesterase 4 inhibitors. Cephalin also prescribed for refractory index and have severe side effects. Prophylactic antibiotics help to reduce exacerbations frequency, but it has risk of increasing bacterial drug resistance. We can use systemic steroid. It helps to reduce duration and recurrence of acute exacerbations of COPD for up to 6 months. Indications for initiation of long-term oxygen therapy. We use long-term oxygen therapy if the patient have reduced air, room air, arterial pressure of oxygen less than 55 mmHg or between 56 and 59 if he already have visited pulmonary or signs of tissue hypoxia. Second indications, if the room air oxygen saturation less than 88 or less than or equal to 89 if the patient have visited pulmonary or signs of tissue hypoxia. The third indications, if the nocturnal oxygen saturation is less than or equal to 88%, we use here oxygen only at night. If the patient has exercise hypoxemia, partial pressure of oxygen less than or equal to 55, or oxygen saturation less than or equal to 88. We use here oxygen with exertion. The oxygen should be used for at least 15 hours per day to achieve a target oxygen saturation between 88 to 92. After pharmacotherapy, we may have to initiate pulmonary rehabilitations, which consists of structured programs to provide exercise training and education and nutritional counseling and behavioral modifications. We use pulmonary rehabilitations if the patient have impaired quality of life and dyspnea that limits activity. The last resort is surgery, and for selected patients, like for example, if they have upper lobe predominant emphysema, or if they have low exercise capacity before they initiate the treatment. Vaccinations regarding influenza is so important. It decreases the exacerbation of COPD and decreases secondary infections. We use annually influenza vaccines in patients with COPD, and we use also pneumococcal vaccination for persons aged 19 to 64 years of old if they smoke or if they have COPD. For exacerbations, we use regular doses of short-acting bronchodilators and continuous oxygen, antibiotic, and systemic steroids. If they have hypoxemia that's untreated by simple mask or We use non-invasive positive pressure ventilations or invasive mechanical ventilations. COPD increase risk of complications and increase risk for having other diseases, like they are more likely to have colds, flus, and pneumonia. So we use vaccinations regarding influenza, and pneumococcal. There's increases of heart problems with COPD, like having heart attacks, and there is a risk of lung cancer. Also, there is association between COPD and pulmonary hypertension and depression, because difficulty in breathing can keep them from doing their activities, and serious illnesses can contribute to development of depression. Idiopathic pulmonary fibrosis. It is a progressive and ultimately fatal fibrosing interstitial lung disease of unknown cause. It is a type of diseases called interstitial lung diseases, which also includes hypersensitivity pneumonitis and rheumatoid lung. It has no clear cause, as its name idiopathic, but unusually affect people around age 7 to 75%. And 70% of patients also have a history of cigarette smoking. It has very poor prognosis. The median survivor is 3 to 5 years. Although it is idiopathic, it has been linked to exposure to certain type of dust and viral infections. And if the patient have a family history of idiopathic pulmonary fibrosis, he also has a risk of developing, and it's associated with gastroesophageal reflux diseases and smoking. The pathophysiology, it occurs that the normal lung is being replaced with a scar tissue, leading to impairment of gas exchange and reduction of oxygenation of the blood. The histopathological hallmark of idiopathic pulmonary fibrosis is alternative tissue of heterogeneous appearance with area of fibrosis and normal appearing lung, giving the appearance of honeycomb. Here we see a difference of normal alveoli, and here is destructive lung tissue. The symptoms tend to develop gradually and get slowly worse over time. The symptoms include dyspnea, dry cough, tiredness, loss of appetite and weight loss, and the characteristic fingers called clubbing. There is a roundness and swelling in the fingertips. The diagnosis is considered in any middle-aged or elderly individuals with unexplained chronic exertional dyspnea. We do diagnosis by doing history, physical examinations. We hear in auscultation, we hear respiratory layers, and we see clubbing in fingertips. When doing lung function tests like spirometry, there is restrictive pattern, and there is decreased diffusion of carbon monoxide. And we order chest X-ray, CT scan, and CT scan, we see the characteristic lesion in CT of idiopathic pulmonary fibrosis, which is subpleural reticulation and honeycombing. We do pulse oximetry and exercise stress test. We do ABG, and the last thing, if the diagnosis is inconclusive after doing all this, we can rely on lung biopsy. The treatment, first we advise about stopping smoking and eating healthy diet and doing exercises. The medications that reduce the rate at which scarring worse. I am not sure about the, it's called nintedanib. First time I heard it, and I don't know how to pronounce. It's intracellular inhibitors of tyrosine kinase, and usually interfere with fibroblast proliferation, migration, and differentiation and secretion of extracellular matrix in the lungs. The second drug is called pirfenidone. Also, it inhibits fibroblast proliferation and differentiation and synthesis of collagen. If the patient also have symptoms of pulmonary hypertension, we can start sildenafil. If the patient has no contraindication to using it. And also treating GI reflex may slow the progression of the idiopathic pulmonary fibrosis. We can do pulmonary rehabilitations as in COPD patients, and the last thing is lung transplant. Okay. Venous thromboembolism. In all patients, the main triggering factors is prolonged immobilizations because people have osteoarthritic changes and people have dementia. And usually they have other chronic diseases, making the venous thromboembolism diagnosis difficult. As symptoms may overlap and confuse or misinterpreted by patients. So the prevention is essential in the elderly who run the risk factors of suffering the embolism, usually by subcutaneous injection of low molecular weight heparin. Most patients with venous thromboembolism are over the age of 65 years. As the patient gets older, the severity also increases. The risk factors for developing thromboembolism are increasing age, prolonged immobility, malignancy, major surgery, multiple trauma, if they have prior history of embolism, or if they have chronic heart failure. Here, risk factors for thromboembolism range from strong risk factors, moderate, and weak factors. The diagnosis, first we assess the clinical probability of having BE. We assess the clinical probability by integration of history and analysis of chronic risk factors, and by doing investigations like ECG, chest X-ray, and ABG. We assess the clinical probability by using scores like WELL score. This is a score. We give point for each one. The highest point is 3 and the least point is 1. We give 3 to the patient if he have clinical signs of DVT like swollen limb, pain in the limb. And we give 3 also if the alternative diagnosis is less likely than BE. We give 1.5. We give 1.5 if there is history of previous PE or DVT, or if he has tachycardia, or he has immobility like recent surgery or immobilization. We give only 1 point if the patient has hemoptysis or cancer. Then we add the point together, and if the score is between 0 and 1, the probability of having BE is low. If it's between 2 and 6, it's intermediate. If it more than or equal to 7, there is high risk of having BE. Then if the score is low, if there is low probability of having BE, we measure the D dimer. If it's less than 500, usually BE is excluded. In old age, there is different D dimer values than the young population, so we can wrongly consider negative if the D dimer is less than 500 in the elderly. So it's considered unsafe in diagnosis. When the probability of having BE by calculating the score is high, we go to NGUCT or pulmonary angiography. We can use leg ultrasound. It's a non-invasive test to detect DVT. The presence of recent DVT is enough to rule in diagnosis of BE, and then we can start anticoagulations. Also, we can use the echocardiogram if the patient is unstable and cannot do complex diagnostic measures, and also give information about the prognosis and stratification for treatment. Here, this diagram illustrates the diagnostic step. If there is suspicion, if the patient age less than 80 years and there is high probability of having BE, we go for CT. If he has low probability of having BE, we measure the D dimer. If it is negative, the BE is ruled out. When we do the CT, if there is BE, we start the treatment, and if there is no BE, this means that the BE ruled out. If the CT is inconclusive and there is high probability, we go for angiography, and if there is no high probability, the BE is ruled out. If the patient age is more than 80, we do legs ultrasound. If there is DVT, we start the treatment, and if there is no DVT, we go for CT. The management of PE starts with anticoagulations to reduce the mortality. Thrombolysis, we add it if there is if the patient is hemodynamically unstable. The vena cava filters are usually indicated when the anticoagulation is contraindicated. A major concern when prescribing a therapeutic anticoagulation in elderly is the risk of hemorrhage, but actually the risk of death from hemorrhage is far less than the risk of death from PE. So we start anticoagulation. We give the patient subcutaneous fondaparinux, or we give him low molecular weight heparin or unfractionated heparin. The ABDT should be between 50 and 70. Then when we start anticoagulations, we start with it oral vitamin K antagonist. Actually, in the first 5 days, we give anticoagulations, and with them we start warfarin. And after 5 days, we discontinue the anticoagulation and we continue with heparin, with warfarin, to target INR of 2.5. The IFEC filters actually have risk of developing recurrent DVT and post-phlebitic syndrome. Long-term anticoagulations is preferred to shorter term. We give anticoagulation for more than 6 months is much better than using it for 3 months, unless there is increased risk of bleeding. Patients with multiple ongoing risk factor for thromboembolism should be considered for anticoagulation for up to 2 years or longer. And if the patient develops recurrent thromboembolism, then he should be treated for lifelong anticoagulation therapy. Regarding prophylaxis of pulmonary thromboembolism, we do it in all hospitalized older populations who are not fully ambulatory to regard against developing thromboembolism. Also in patients in transitional care or long-term care residents at increased risk of like subcutaneous unfractionated or low molecular compression of the calves. Pneumonia. In the elderly, the incidence and prevalence of pneumonia are 4 times higher than the younger populations because the senile lung favors development of pneumonia more than young population, and almost 1 million adults over the age of 65 years are hospitalized with pneumonia in the US. There's types of pneumonia like community-acquired pneumonia, healthcare-associated pneumonia, and aspiration pneumonia. The classical symptoms of pneumonia are productive cough, fever, chills, chest pain, fatigue, shortness of breath, and rapid breathing. Actually, these symptoms in older population may differ from the other age groups. Like in older adults, they feel weak or unsteady, which may increase the risk of falling. They may be no fever. Actually, they may have decreased body temperature, and they may experience confusion or delirium. And they may experience urinary incontinence, and they have lack of appetite, and they may have experienced a worsening of existing health conditions. So symptoms in elderly patients differ from young populations. Diagnosis through history, physical examination, and twin investigations like blood test, imaging, pressure, pulse oximetry, and we can do also PCR if we have suspicions of influenza or COVID. The management of pneumonia starts with stabilizations by fluid oxygen therapy, over-the-counter medications to reduce, for example, fever, antibiotics, macrolide, fluoroquinolone, or beta-lactams. If the pneumonia is due to virus, the treatment is supportive care, such as easing symptoms, maintaining hydration, and monitoring vital signs. In some cases, we may give antiviral drugs. Elderly population need prevention for developing pneumonia, like pneumococcal vaccines. This help to prevent pneumonia due to Streptococcus pneumoniae. There are 2 types of vaccines for adults over the age of 65, the BBSV23 and BCV13. you may qualify for a pneumococcal vaccine before aging of 65 if the patient have weak immune system, like AIDS patient, or if they have chronic lung, kidney, or heart conditions. In these conditions, we can give the pneumococcal vaccine before the age of 65. Also, elderly population need an influenza vaccine yearly. Pneumonia is a potential complication of flu. So if the elderly patient develop flu, it's a risk factor for developing pneumonia. So there is a high dose flu vaccine that is especially formulated for adults aged 65 or older. The last thing is obstructive sleep apnea. This type of apnea occurs when your throat muscles intermittently relax and block your airway during sleep. The most noticeable signs of obstructive sleep apnea is snoring. Here we see this is a normal upper airway. The air goes easily, and this is a blocked airway in obstructive sleep apnea. Aging is a risk factor of OSA because there is age-related changes of respiratory anatomy and physiology, such as there is increased upper airway deposition, and there is pharyngeal bony changes which may predispose older adults to sleep apnea. Also, other risk factors like medications, alcohol, and abnormal upper airway configurations are also risk factors for OSA. Also, hypertension is a risk factor, smoking, diabetes, in addition to having a family history of obstructive sleep apnea, and asthma also is a risk factor for obstructive sleep apnea. The symptoms of obstructive sleep apnea is excessive daytime sleeping because the patient is sleep deprived during the night, so there is excessive daytime sleepiness and loud snoring when he sleep, and there is opposite of stop breathing during sleep, which is apnea. Also, there is abrupt awakening accompanied by gasping or choking, and the patient also awake with a dry mouth or sore throat. There is morning headache, I think, due to CO2 retention, the difficulty in concentrating during the day, and mood changes such as depression or irritability. Also, patient can develop high blood pressure and decrease libido. You are diagnosed by doing polysomnography. Obstructive sleep apnea can increase the risk of developing daytime fatigue and sleepiness and cardiovascular problems. There is increased risk of having coronary artery disease, heart attacks, heart failure, strokes, and arrhythmia. Also, the patient develop memory problems, morning headaches, mood swings, or depression, and they need to urinate frequently at night. The treatment of obstructive sleep apnea starts with lifestyle changes. Some patients, if they can lose weight, it helps in resolving. Exercise, quit smoking, using a nasal decongestion, and advise them to not sleep on their back and avoid taking sedative drugs. If this doesn't work, we go to positive airway pressure, for example, through a CPAP and mouthpiece. We put on an oral device. The last thing is doing surgery. Okay, I finished my presentation, but there is a couple of questions. 68-year-old woman seen 1 week after discharge from the hospital, where she was treated for exacerbation of COPD. She is back to her baseline respiratory status. She has an intermittent cough. She tires after walking half a block. She has history of diabetes and formerly smoked tobacco. Her COPD medications include short-acting beta-agonist 4 times daily PRN, inhaled long-acting muscarinic antagonist. On examination, she is seen oxygen saturation is 94 at rest, 87 after she walks 12 meters. Chest diameter is increased, breath sound are decreased. Spirometry, forced expiratory volume in 1 second is 56%, and the ratio is 0.62. Bronchodilator therapy does not refer to obstructions, and chest X-ray show hyperinflated lung. Which one of the following interventions is most likely to reduce the risk of mortality? She is a COPD patient. A treatment with inhaled steroid treatment with inhaled steroid and long-acting beta agonist, pulmonary rehabilitation, and oxygen supplementation during exercise. She already is in short-acting beta agonist and inhaled antimuscarinic antagonist, and she has symptoms despite this treatment. So what we should do next? Answer C, we should start pulmonary rehabilitations, which include programs like exercise and nutritional counseling. Second case is 77-year-old man comes to your office because of his cardiologist recommend a sleep study to exclude obstructive sleep apnea. In questioning, the patient says he has a history of snoring and daytime somnolence. He is reluctant to have the sleep study because he is not bothered by the sleepiness. He is retired and naps when he wishes. He recently underwent a cardioversion to sinus rhythm. Holter monitor recorded a nighttime episode of sinus arrest with pauses up to 6 seconds. No pauses or bradycardia was noted during the day. He has history of diabetes, hypertension, and AF. If OSA were diagnosed and he was treated with nighttime positive airway pressure, which one of the following would be true? His risk of sudden cardiac death would decrease, or the risk of coronary artery disease and stroke would decrease, or daytime somnolence would improve, or the risk of dementia would decrease. So the patient has diagnosis of obstructive sleep apnea, and he has treatment with PAP, which is positive airway pressure. Which of the following is correct? Yes, the correct answer is C. Daytime somnolence would improve. Actually, there is no data on that. The treatment of sleep apnea would decrease risk of sudden cardiac death or coronary artery disease. Thank you.
Thank you so much, Dr. Amna. Any questions?
Yes,
These
Dr.
are
Amna,
shared
if you don't mind.
Go ahead. Go ahead.
Okay. Dr. Amna, you mentioned in, I'm always confused about this term. So in the idiopathic lung fibrosis, that's usually, and you included, I believe, extrinsic allergic alveolitis, or what we call it hypersensitivity pneumonitis. So you've mentioned that the pulmonary function test will be restrictive. Am I right?
Yes.
In fact, just we had a case like 2 weeks ago. I believe usually pulmonary function test here might be a mixed pattern. So when it comes to the diagnosis, I think the recommended kind of test will be bronchoalveolar lavage, because at certain time of point, it might be restrictive, then it might come like obstructive. I'm not sure about that, but just I want to share that kind of point, because the case we had, we expected to be restrictive, and then the pulmonary just mentioned it's always a mixed pattern. So that's my point. Thank you.
Okay, thank you. I think because in elderly populations, we have changes in the lung, and so the diagnosis may be more difficult. I'm not sure the case you mentioned, the patient's elderly or young.
He was elderly. Yeah, he was, I think, 75. So we can consider him like an elderly. So that's the point. I'm always, I think I was expecting the same. It could be a restricted better. That's
Okay.
it. Thank you.
Dr. Nader, maybe you comment about it.
Thank you for the question. Thanks for the answer. I think I agree with you, Amna. As we get older, there are some changes, and some might have some impact. So one question for that is, let's say, does the patient smoke? If the patient smoke, they put themselves at a little bit higher risk of obstructive lung disease pattern, and that might also combine the result when you are talking about this lung disease. Sometimes they may have some chemical exposures, sometimes may have some genetic exposure. So all these can contribute to some of the changes that we see in the pulmonary test. So that's a good question and good guess. Thank you. Any other questions? Anything else? That's a great presentation. Actually, both presentations were excellent. Thank you so much for both of you. Mohammed Tijani, go ahead.
Assalamu alaikum, everyone. Thank you so much, Dr. Amna and Dr. Sulafa, for the great presentation. It's not a question as much as just a point I would like to actually open for discussion. The comorbidity between any of these chronic lung diseases and the relative polycythemia, which usually develop as a result of the chronic hypoxia. From what I've read many times, this relative polycythemia can even be severe to the point it can trigger some kind of left ventricular failure, or at least worsening the left ventricular functions in the form of ejection fraction, and the other at least can trigger some sort of left ventricular failure. If anybody had any input to add here, it would be great. Thank you.
Dr. Hassan, you want to go ahead?
No, thank you, Dr. Nader. I have no idea about that.
So maybe Mohammed Tijani, can you repeat the question just a little bit?
It's not a question. It's just association. I wrote many times in some text, literature about this correlation between chronic lung diseases like COPD and polycythemia, or relative polycythemia, which usually develop because of this chronic hypoxia due to the COPD. And that by itself, the polycythemia can trigger left ventricular failure, which definitely going to make the patient suffer more because of this comorbidity between lung problem, chronic lung problem, which now going to lead to cardiovascular problem, or if I remember that's a core pulmonary or pulmonary. Been a long time. All right, that's a point. I would like to share.
Thank you so much. Thanks. Any comments from?
I think lung diseases lead to right heart failure, right? Which is pulmonary, not left heart failure. Hello?
Yep.
Hello?
Yeah,
I think lung disease lead to right heart failure, which is pulmonary, right?
Yep, you're right. Yep.
You said left heart failure. I'm not sure that about polycythemia, if it can lead to left heart failure or not. I'm not sure about that.
excellent. So again, the idea here is to go over what happens as we get older. Some changes happen, and what comorbid conditions that you may face when you practice. When you see older patients, think about the pathophysiology, the changes, and then the multi or comorbid conditions that the patient comes, along with other aspects, their social life, their history of working in certain environments that can put them at exposure. They may be exposed to chemicals or environmental factors that can play a role. Thank you so much. Any other comments? Any other questions? Excellent. So I just want to add to the point that, or to the discussion. It's very common, like COPD in older adults. And when we see it, most of the time we try to maintain the health of the patient, but sometimes they come into an acute phase where it's an acute exacerbation. So in that case, I think the management would be focusing on getting them back to their baseline. They're not going to go back to normal as when they were younger, but your goal is to minimize their deterioration, and as much you want to get them back to their previous baseline if possible. One thing you consider is the advice of smoking cessation. It's very important to talk to all patients about that, but specifically patients with COPD. So, thank you. Anything else on this topic or in general, as far as pulmonary disease and alcohol or any comments? Okay, if not, then Lena.
Okay. Thanks, Dr. Amna, for the informative presentation. Now, Dr. Afrah will present the critical appraisal topic.
Assalamu alaikum. Hi, everyone. My name is Afrah Shrabi. I will talk today about critical appraisal. I will start by brief introduction about critical appraisal. So, definition of critical appraisal, it's a systematic process used to identify the strengths and weaknesses of a research article to assess the usefulness and validity of research findings. In simple words, critical appraisal is the process of weighting up evidence to see how useful it is in decision-making. Why critical appraisal is essential? Many of the research are not in good quality, and many studies are biased and the results are inaccurate. Also, this can lead us to draw false conclusions. If these false conclusions are applied to population, this leads to a public health problems. So, in order to prevent that, clinicians identify the most relevant high-quality studies available to guide their clinical practice. The most important component of critical appraisal is careful assessment of the study design. Also, evaluation of the statistical methods used, interpretation of the findings, and potential conflicts of interest are also essential. Assessment of the relevance and validity of a research article. Generally, there are 10 questions. First one, is the study question relevant? Does the study add anything new? What type of research question is being asked? Was the study design appropriate for the research question? Did the methods address the most important source of bias? Was the study performed according to the original protocol? Does the study test a stated hypothesis? Were the statistical analysis performed correctly? Do the data justify the conclusions? The last question, are there any conflicts of interest? And because we have several types of studies with different types of strength, critical appraisal scale program coordinators have developed separate checklists for the appraisal of systemic reviews, RCTs, cohort studies, case control studies, diagnostic test studies, economic evaluations, and qualitative research that each comprise 10 questions. Today, we will discuss systemic review checklist. I don't know how to say this. Okay. So yesterday we sent the article into the WhatsApp group. I hope that you read the article. We will discuss the D-dimer level in COVID-19 infection systemic review. So the checklist, contains 3 sections. Section A, are the results of the review valid? The first question, did the review address a clearly focused question? So we look at 3 things: population, intervention, and outcome. If you look at the result of the study, D-dimer level in COVID-19 infection. So we can consider COVID-19 infection as the population. And because we don't have intervention here, the outcome here is either survival or mortality, mild and severe, also mild and severe disease. You can find the outcome here. So the answer of this question could be yes, because the population identified, the outcome also is clear, but the intervention is not applied to this study. Anyone has another opinion? Feel free to interrupt me and express your opinion if you have another opinion. So second question, did the authors look for the right type of papers? The best sort of studies would address the review's question, have an appropriate study design. If we look at this study, so the authors, the criteria for inclusion were the text written in English, not this. The studies with inadequate data and contact letters to the editors were removed from the report. So at the first there was 251 articles, and then they removed the duplicated articles, those who are without enough data, and then the included articles were 71 articles. So we can say the authors look for the right type of paper. So here the answer is yes. Is it worth continuing? Yeah. Yeah.
Yeah. Why you are agreeing with it? It's yes.
Sorry?
Why you said look for the right type of papers?
Because they exclude any papers that are not included in their criteria. They excluded the data that the articles that contain duplicated data or the not enough data.
Okay. All right. Thank you.
Yeah, I agree with you. Yeah, they took all the previous papers and excluded any data that have nothing of that.
Okay, that's a point that I missed. Okay.
Thank you.
By the way, I sent the paper in the chat box.
Mhm. The third question, do you think all the important relevant studies were included? Here, the hint, look for which bibliographic database were used, follow up from reference list, personal contact with experts, unpublished as well as published studies, non-English language studies. So in this study, they include text written in English and published studies. What other else? So I think in this question, we cannot tell they include all relevant studies because they just, they include only the English written articles, published articles. What do you think? For this,
yeah, or we can say no because they don't include the English papers. And also they didn't tell about the reference list or follow up.
Yeah, they didn't include follow up from reference list. Yeah, you're right. Fourth question, did the reviews authors do enough to assess quality of the included studies? I didn't find anything that point to that the authors assess the quality of the included studies. I read the whole article. I didn't find that. If anyone find, can share with us. Other than inclusion and exclusion criteria, they didn't assess the quality of each study. So for me, cannot tell. Do you have other opinion? Okay. Fifth question, if the results of the review have been combined, was it reasonable to do so? So consider whether results were similar from study to study. Results of all the included studies are clearly displayed. Results of different studies are similar. Reasons for any variations in results are discussed. So we will look at results. So they combined all articles, 71 articles, median D-dimer in 71 articles was 1.53. But if we see the study population were children, diabetes patient, cancer patient, pregnancy, patient with diarrhea, patient with stroke, patient with VTE. For me, they combined the result, but I think it's not reasonable to do so because every population has its D-dimer level. For example, in pregnancy, is normally to find or physiologically find high D-dimer, and also in cancer patient. So I think those can affect the overall result. This is my opinion. So here, I think if the results of the review has been combined, was it reasonable? No. Do you have any other opinion? Also, other thing, they say the results were similar from study to study. If we see here, I think patient with diabetes, the results were different. The dimer was low, not here. The dimer was higher in non-COVID-19 pneumonia patient. So the result here is opposite to the in 44, not in 44. So in several types of studies that included in the all study, The result was opposite to the main result, which is COVID-19 patient with high D-dimer level. So I think it was not reasonable to combine the results. Section B about the results. What are the overall results of the review? So the overall was, if we see the conclusion, D-dimer measurement is a laboratory test needed for the evaluation of patients with COVID-19 in view of the fact that thrombosis. No. So the overall result was increased D-dimer in patients with COVID-19. This one. The median D-dimer was 1.53. Then they discuss every variable separately, like patient with diabetes. With patient with diabetes has high D-dimer than those without diabetes. Pregnant patient also has high D-dimer with COVID-19 other than non-pregnant patient. Cancer also. Stroke also has, patient with stroke has high D-dimer. Except those with pneumonia, they have low D-dimer. COVID-19 with pneumonia has low D-dimer. So those are the results of the review of the study. How precise are the results? In case of precision, we look at confidence intervals. I didn't find confidence interval in this study. And they didn't report significant p-value in each variable. The 8th question, can the results be applied to the local population? Consider whether the patient covered by the review could be sufficiently different to your population to cause concern. Your local setting is likely to differ much from that of the review. So this is about external validity or generalizability. So can we apply the result to our local population? If we look at the study, it was in China population, just one study in USA, and 4th in Italy. And they included different ages, both sex. I don't know if we can apply the study to USA patient. For me, I would say yes, because I think COVID-19 can affect all populations, so there is no difference between Chinese, European, or American. So we can apply the study to our local population. So for this question, yes. What do you think?
Yeah, I agree with you. Yeah, because the study is done in different countries.
Mm-hmm. Okay, thank you. The 9th question, were all important outcomes considered? Consider whether there is other information you would like to have seen. So the outcome in this study was, if you look at this, increased rates of D-dimer have significant connection to mortality according to a real study. 9 papers examine the relationship between D-dimer levels and rate of survival. So they mentioned the survival mortality rate. They mention also here the mild and moderate, mild and severe disease. So for me, the outcome is the all important outcomes considered. Yes. The 10th question, are the benefits worth the harms and costs? Actually, I didn't understand this question because there is no harms and cost of this intervention. So cannot tell. Okay, so we finished the 10th checklist to assess the systemic review article. Do you have any comments or any question? Okay, thank you so much.
Thank you so much, Dr. Afrah. I think Wale, we have question or comment. Go ahead.
Yes, thank you, Dr. Afrah. Thank you, Dr. Nadi. I think, yeah, also we can just like just to extend more of what she said regarding the external validity. So generalizability, we can just, for the systemic review, we can compare all the study and see, for example, the eligible population that they cover. And this population, like kind of we can, because later on we think about the inference of the study. So also the source of population, it's represented the study that we want, male, female, women, gender-based. Also, as I think Dr. Tahani mentioned, so the kind of the similarity of the population for the studies. And also, you mentioned that you couldn't find confidence interval, but also we can just kind of assess the strengths of association by the relative risk, and you can look for the relative risk of each study. The larger relative risk means strong association between the exposure intervention or the events on the population. Thank you.
Thank you. Yeah, you are right about the precision, but I didn't find any confidence interval or relative risk or association. They just report it as mean and median. For example, high in those and in those, just. So I can't tell in this study how's the precision. Anyone else has comment?
Thank you again, Dr. Afrah. This is great. And, thank you, everyone, for the discussion. I think there is one chat box. Go ahead, Lubaba.
Hello, good afternoon. I'm kind of in a noisy area, but
Sure.
That was really great presentation, Dr. Afrah. I just want to go, like she said, the last question, she didn't understand what that mean. Yeah, not all of these. For example, systematic review just would be like the time and effort that the researchers did kind of finding this kind of results or conducting such a study. And I think it's worth it since COVID-19 is something new and we need to learn more about it. But I agree. So there is no harm in doing such kind of reviews. There is no involvement of human or animals or anything that we could think about that might impact them negatively. But thank you. That was great. Thank you.
Thank you.
Thank you, Dr. Lubaba. And again, thanks the presenters on the review. We can move on. Lina.
Thanks, Dr. Afrah, for the presentation. Now we'll have the project update.
So we have two posters already accepted at Amna. So there are two teams working on them. Can we get an update from any of the teams? And then we have another abstract submitted for another conference. conference, and we are waiting for the reply from the conference.
For the long COVID project, we're still in the preliminary kind of stages. We will have our next second meeting tomorrow morning to discuss more steps and what we would do. We will keep you posted. Thank you.
Go ahead, Al-Wali. Thank you so much.
Yes, thank you, Dr. Nadir. Actually, one of our projects we received, like they want us to have a handout. So just would like you to explain a little bit about what we're gonna do. We got the handout.
So basically in the abstract, if you are going to present and you will be in person presented there, usually the poster will be the big poster hanging into a wall, and then it will be presented there, and people will come by, will read it, and if they have questions, you can answer them. And during that time, before COVID, some of the presenters might bring like a one paper sample with the same content of the poster, and sometimes they may add additional references. For instance, in the poster, they can put, let's say, up to 3 references, but when they did the research, they used 5 or 6 references. Then they can add that into their paper format, a small 1-page handout. So this handout can be only the poster in the past, like people can take it home and refer to it when they have some time, look into the detail. And if they want to go in depth, they can go into the reference list and verify or get more information from the references. So this is what the handout used in the past. With COVID, things changed. So the poster is virtual, mostly last year and the day before. And now they want to go back to the old days, like the actual poster printed and presented. But there is some conferences where they want to do either or, the both option, virtual option and the actual in-person option. So Amna, I think they want to do both this year. They want, if you are able to go physically in person, you bring the poster, and if you want to put some hands out, so people who come, they can ask questions, they can get the actual paper format hands out. Or if you want to present it virtually, you can do the video and then the slides for the, like PowerPoint slides. And this will be displayed in their website along with your video or recorded audio. They are asking the handout. So I assume it will be the same. So you just print one sheet, one paper, same information, just the same poster, kind of just in a small paper. If you want to add any additional information, you can add them there. One of the information, maybe the contact email. If they have questions, they can contact the main responder for the poster, for instance. I hope I answered your question.
Yes, thank you.
You're welcome. Anyone else? So how far you and your team in the process now?
Yes, so actually, I think Dr. just arranged 3 groups. One of them is kind of preparing for the handout, other recording. And so, yeah, we're doing very well. I think kind of almost ready, inshallah.
Excellent. So in the past, what we did when we had this prepared, we had one or couple of the team presented that work to the group here so they can get some feedback. And it will be just a practice for those who will present. And maybe they will also practice how to answer questions. So maybe we'll have some, for the practice, some questions will be asked and then the presenter will try to answer them fine.
Yeah, absolutely. We'll do that. Thank you.
You're welcome. Any other updates? How is the other group doing? No information. That's all right. Any news from other conferences or other projects? Any ideas? Any one of you wants to add? No comments, no updates. That's fine. We can go to the next section.
So the next section will be the next meeting agenda.
Okay. Any suggestions?
Yes, Dr. Nadir. I have a suggestion.
Yes.
If we can have like a short session every week about the update of COVID-19, the new mutations, the vaccination covering all over and here in the United States. Yeah, things about that.
Sounds good. So in the past, we did that when it started. So we divided the teams. Each team has a certain area. So it's up to you if you want to do it team by team or each week we can work a little bit. So the presenting team, they can work on some like 15 minutes presentation on any update as far as information regarding COVID. So any specific topics you want to discuss, let's say for next week, any suggestions? So I put some suggestions here. If people agree, maybe we can add something or remove something.
Yes, Doc, I am okay with the neurology topic presentation.
Sounds good.
Mm-hmm.
And all this just for the team and all the fellows. I'm putting names here, just I'm selecting from the list of fellows according to the team. And some of you might not be available, let's say, for next week. For instance, I put Sarah and Matt and Vinash for these. So if Sarah, for instance, is not going to be able to attend or present, maybe someone else from the team, they can cover or take that topic. Or maybe someone from other teams, let's say Lubaba or maybe someone else can say, hey, I want to present this kind of things. Does it make sense to you guys? So we work with teams just to organize things and divide the task, but this doesn't necessarily mean you have to. And we know people might have other obligations or other circumstances that they may be busy preparing for step 3 for other family issues. So if the team, any one of the member is not able to, maybe the team leader can, or someone of the other team members can jump in or can ask some of the other fellows to help with covering that area or task.
Yes, that's
so
fine.
Thank you so much.
Yeah,
Anything else?
That.
Thank you so much. Anything else we want to add to this? One mentioned the COVID. Maybe we can add it from here. Maybe 10 minutes. Someone might answer this. And this also might be 10, 15 minutes. Just quick, just similar to what Dr. Afrah mentioned. Wonderful. All right. I think we are done for next meeting agenda, unless anyone of you wants to add or set the record. If not, then one more question before we conclude this meeting. Any other input from you, any feedback, any reflections as far as this fellowship? Now we spend about, let's say, 5 months or how many months? Anything we can change, anything we can improve on? So if you have any, just shoot me an email or send me a text, so we can talk over the phone and see what other things that we can make. In the meantime, I'm in the process of preparing for next batch of the new coming generation of fellows. So if you have anything that when you started, you think it wasn't clear for you, or it was a little bit not the way you wanted it to be, the process of the application itself, the selection, or any suggestion as far as we can improve in these areas, please let me know. Thank you. Okay. Thank you so much, Lena, and all the presenters and all fellows present now, all the fellows who can view the recording later. Thank you so much. Have a wonderful day. Bye. Assalamu alaikum.
Thank you so much, Dr. Nader.
Thank you so much.
Bye.
Yeah.
Thank you.
Thank you.
Thank you. Have a good weekend.
Thank you.
Thank you.
Thank you.